All right, please be advised this meeting is being recorded. Take it away, Amber.
All right, thanks everyone for joining. So we can run through these drug profiles that were recommended to be added for the tox box related medications. I think everyone knows everybody here. For those of you who don't know me, I'm Amber Rice. I'm a medical director down here in Tucson, and on the PMD committee.
And I don't think Tanner knows most of the group.
Oh, really? Tanner,
Yes.
do you want to tell us about yourself?
Sure. I'm Tanner Perkins, worked for Mesa Fire Medical Department for the last 13 years. I was with Southwest Ambulance prior to that. Part of our hazmat team, and I kind of got tasked with overseeing our toxicology program. So I've been down there and learned from Dr. Walter and been up here working on our program. And so I've shown interest, and thus I'm kind of leading the charge. So
Great. Well, I appreciate all the work for sure. So thank you. And what about Franco?
So I'm Franco Castro-Marin. I'm the PMD chair. I'm a base hospital medical director in Scottsdale, Arizona.
And Shari.
I'm Shari Brand. I'm base hospital medical director for Mayo and medical director for Rio Verde and on PMD.
Super duper. And Shelly, do you know Tanner?
I don't. Tanner, my name is Shelly Osel. I work at the Bureau of EMS and Trauma System, and I help coordinate stakeholder meetings. I'm glad you could join. I'm trying to figure out how to make this bigger.
So I think there's not a large number of these. So I think if we just kind of go through line by line or drug table by drug table and see if there's anything we see preliminarily. The style has not been to put dosing on these, so I don't think we need to get into dosing a terrible amount, but we can kind of walk through these and see what we see as a group. And I think a lot of times the indications, and especially the sort of relative contraindications, tend to have some discussion. So we'll take a close look at those and make sure that those look like they make sense operationally. So operationally, those can be problematic if we write them in a difficult way. But this first one, it looks like sodium nitrite. Interacts with hemoglobin to form methemoglobin, which has a higher binding affinity for cyanide and prevents it from entering cells and causing toxicity. Similar mechanism for severe hydrogen sulfide poisoning. So these would be the two indications. Are going to be antidote for cyanide poisoning. Can be used for hydrogen sulfide, but not always indicated. Absolute contraindications is none. Precaution side effects, hypoxia, cyanosis due to formation of methemoglobin, hypotension, tachycardia, tachypnea, syncope, vasodilation, vomiting, dizziness. You can see those there. And then we have our administration routes, and then our link to the cyanide and hydrogen sulfide guidelines. For this one, the notes I had for indications.
Shelly, are you able to make it a little bit bigger? I see Amber's doing the same thing I am, which is getting super close to
We all are at this point.
My choices are 200% or 100%. So
Or maybe get rid of the thumbnails, Kelly. Maybe we could get rid of the thumbnails or something. Maybe that would help.
I would, yeah, like maybe slideshow format.
Oh, yeah, that's a good idea.
I just had my eye exam. She said I don't need readers yet, but I feel like looking at this that I might.
Oh, just wait, because this is with the readers that I need more. I need it bigger.
Just from a stylistic point on the links at the bottom, we usually have been typing out the entire title of the protocol that they link to. So cyanide poisoning would be cyanide poisoning : adult and pediatric.
Thank Yeah.
And I
Somebody
did
else
recommend-
wanted to say, I don't know how to work this.
Hmm.
I'm not 100% proficient in Google Slides.
And just, I want to say thank you to Tanner because he did all the legwork and putting these few ones together to start with. So
Yeah.
big thank you for that. One other thing just that we probably do want to look at as well is maybe looking at table 2 as part of this to see, are there any drugs that are on there that we want to potentially remove from table 2?
Yeah. I was thinking that as well, because I had some notes of things that I would recommend removing, but I don't. You want to start there, Gail, or do you want to go through these first?
We can go through these first. I just wanted to make sure that I kind of put that out there for part of the discussion too.
Yeah, there were some that I think probably are, I don't know.
I'm
Less
feeling
ideal.
like a complete failure. Just present mode.
Shelley, you're never a complete failure.
Well, it's happening now.
That's a little better. That's fine. That's a little better. So for this one, it says no absolute contraindications. I would say that from when I hear Frank teach about this, I mean, we really don't want to give it in patients that have hypertension already, or if they're already have hypoxia or carbon monoxide toxicity. So I don't know, my feeling is that maybe some of those should be more absolute contraindications than precautions. Just in the way that I feel like teaches this in the tox medic courses and in the textbook.
Mm-hmm.
I don't know how you guys think about it, but
I mean, I think we could, we have absolute contraindication. It says none, then semicolon use with caution with significant carbon monoxide poisoning or smoke inhalation.
Yeah.
So to me, that would be more of a precaution, that piece,
Mhm.
because it's not an absolute contraindication.
yeah.
I mean, I think if the teaching is, and maybe that's a question we can have for Aaron O'Connor to look at as well as Frank, is would you consider this an absolute contraindication like hypotension? And what was the other one you said, Amber?
Hypotension, like the smoke inhalation, carbon monoxide poisoning.
Okay.
Only because in the pre-hospital setting, I don't know. If I mean, you could potentially kill somebody, right? I think in the pre-hospital setting, my threshold for something being contraindicated is a little different than maybe it would be in the hospital. But at least my thoughts are in the pre-hospital setting, we should not be giving this to patients with smoke inhalation or with shock or hypotension.
I originally had this written as an absolute contraindication for smoke inhalation. And when I sent it off to Dr. Walter, or sorry, not Dr. Walter, Dr. Brooks, he had actually changed it to what it currently says. And I'm looking through the AHLS handbook right now, and it has absolute is just allergy, and then relative contraindications. It has all those things that you talked about, Amber.
That's the provider textbook, though.
This is the instruct. Well, yeah, same provider.
Yeah, I mean that. Yeah, so that book is written for. I mean, it depends on, I guess, what we want the style of this to be, but the textbook's written for all levels of providers, including in the hospital. So I agree. I think that in general, it's probably more of a precaution. My concern is in the pre-hospital setting, I think the risk would significantly outweigh the benefit in giving it in patients. And maybe I think is just, I don't know, maybe not overstated enough. The way it's written here, but I don't know. We can see what the toxicologists say, but
So maybe that would be, for now, maybe move hypotension up to the absolute and then highlight those as our questions of how we want that worded regarding smoke inhalation and hypotension.
Yeah, because it's definitely will cause severe hypotension. If they already have hypotension and you give it to them, you will make them go into cardiac arrest. I mean, I think it's just a really risky thing to do in the pre-hospital setting. But
That, I mean, to me, that seems like a good contraindication. For
yeah,
sure.
Don't make
I
the
mean,
worst.
ask-
Yeah.
I mean, we certainly could ask, you
Yeah.
know, the Frank and Aaron what they think about how it's worded. If they think it's too strong to put it as an absolute contraindication, I just think in the pre-hospital setting, we're usually a little bit more mindful in our drug profiles about that. But yeah, otherwise it looks good. Does anyone else have any other comments on this one?
Mm-mm.
No.
Can we maybe take the yellow highlighting off all the other parts and then just highlight the use with caution
The
for
contraindications.
carbon monoxide poisoning or smoke inhalation, hypotension, just highlight that as our question for them.
Good idea.
I can try. Sometimes when it goes from PowerPoint to Google Doc, it loses flexibility.
Abilities, yeah.
I'm just going to make a note for myself here.
Okay.
Absolute.
Sounds good.
Okay. Moving on to the next slide.
Guidelines is also spelled wrong on that last one. It looks like it's spelled wrong on all of these. Guideliness.
There we go. All right.
And then,
Sodium.
if you can just make it a note at the bottom, Shelley, the links for the guidelines, what Franca mentioned, just to have the actual, have it match the guideline name.
Oh, okay. All right. Slide 2, sodium thiosulfate.
This is good practice for us using Google Slides for this, because when we need to update the TTTGs next time, we will have to keep it in Google Slides. Which I think once we get good at them will actually be helpful so that there's not
Version
confusion
control.
amongst
Yeah.
versions. Yes.
I'll put it
But
in present mode for that.
Shelley may have to find a class for me.
Dude, I need a class.
It's fine.
For the quick question, because I'm not real familiar, do the tax medics use them both separately, or do they use it as the nithiodate, the combined?
Usually combined, but there are indications to use them separately.
Okay, because I don't know if we needed to put that anywhere in there, that if it makes a difference,
Yeah.
like a reference to it at all.
And so Shelley, for your notes, again, the typo at the bottom for guidelines, and then the full description of the link at the bottom.
Right.
All right.
Thanks, Franco. I think otherwise this one looks pretty good. I don't have any specific comments.
Not much.
I don't know very many tox medics that carry these two anyways, but
Would the contraindications here be similar to the sodium nitrite, or
No.
as a separate drug? It's not a word, but together when we're talking about carbon monoxide poisoning, we don't want to give them.
yeah, it's the amyl nitrite that has the significant problems with hypotension, and because it causes methemoglobinemia,
Correct.
If you have a patient with smoke inhalation who's already hypoxic or they're already anemic, you can cause some significant problems. The sodium thiosulfate's a little bit different. It's removing the methemoglobinemia. So you can get some hypotension, but it's not nearly the same.
And people don't usually steal it as much either.
Very true. It doesn't have a street name. So yeah, I don't know. I mean, I actually don't know of none of our tox medics in the Southern Arizona region carry either of these drugs. We only carry the cyano kits. So the whole Southern Arizona regional hazmat team, none of them carry this.
Last time I did some research on this up here in the Valley, we had I want to say one department that had the nithiodate kit, and then we had one department that had the two separated medications.
I mean, I guess that's the question is, well, I guess there's two parts to that is how long ago was it? Have people switched over just to the cyano kit? And then the other question would be how many times do we see, even rare event as it is, drug shortages? Do we need to keep it on in the event of drug shortages versus, but I mean, I wouldn't think that the cyano kit, the cyano kit's pretty straightforward. And they run out of,
I think the indications, I think that the indications to use it primarily are smoke inhalation injuries and carbon monoxide from smoke inhalation. That tends to be one of the only reasons that we use it, at least locally, our hazmat team. So we just don't even keep the nithiodate anymore. We only use that one because it's the only one that's really appropriate. So I don't know.
I think for the biggest problem that we were having with the local hazmat teams was the sheer cost of the cyano kit. It just became more cost effective to carry the other one.
Yeah, but when it's never indicated or when it's always contraindicated, because almost every one of these cases are going to be cardiac arrest from cyanide toxicity. So you can't give it in cardiac arrest. So, risk versus benefit, I guess. But yeah, but otherwise, I don't have any specific comments on this one.
All right. Methylene blue.
Our next one's methylene blue. Used in the treatment of hemoglobin toxicity. Converts methemoglobinemia back to normal hemoglobin and reverses hypoxia. Acts as a reducing agent, invert iron and methemoglobin from iron, regenerating normal hemoglobin. Symptomatic hemoglobinemia can be used for severe refractory vasoplegic shock. Okay.
I don't know that we use the term vasoplegic in any other
we don't.
printed literature we have.
Yeah, you could just say refractory shock. Severe refractory shock related to methemoglobin toxicity. Or actually, you could use it in shock in general. I guess that's probably what it's meant for. I don't know of anyone using it just in shock, though, because it would not be on any other truck other than a hazmat truck. So I think we probably could take that one off, to be honest. Because yes, it's a pressor, but the tox medics would never be using it as that.
What do you think about maybe treatment of symptomatic methemoglobinemia and in parentheses, including shock?
Yeah, but it's not for shock related to methemoglobinemia. It's just for shock in general.
Okay.
They use it as just a regular pressor.
Oh, so your point is that it's known to be helpful in undifferentiated shock, but that's not our application.
Yeah, because we can't have it on regular trucks. We can only have it in the tox box. So it would just never be available to someone treating shock in general. But the hazmat truck's not going to get called for a patient in shock.
Yeah.
It's not a great pressor either.
No.
Not that dopamine, but
Push dose epi.
better than methylene blue. But yeah,
Am I removing that line then?
Yes.
I think so. Yeah, it just doesn't make sense in this context as
Yeah.
a tox box drug. We teach it to our critical care paramedics as a potential treatment for shock, but
I mean, I don't even know if there's any big studies on it. I think it's pretty small studies that really have, you know, we have other agents that, I mean, that would never be something I would even consider.
Yeah.
Giving in a undifferentiated shock patient.
yeah. Yeah, the rest of this looks great. We don't have a guideline for it.
We need to, the bottom heading guidelines containing methylene blue, if that can be put in all caps.
Good eye, Franco. I don't know. I guess it would make sense to have a guideline if we're
Having a drug?
having a drug
Yeah.
for it. We sort of have usually created one. It's be fairly simple and straightforward.
I think we will need to, we've got plenty of time before PMD. So PMD is in November. The NASEMSO model EMS guidelines are out for public comment. So we're going to be sharing a survey link for public comment at the statutory meetings later this month. So we'll distribute that out if anyone hasn't received that. So we'll be starting hopefully as soon as those get finalized in 2022, kind of the TTTG updates. But I think in the meantime, if we've got the drug profile, we could, and then the guideline, we could potentially add that in November and have it go to MDC in January for review.
Mm-hmm. Mm-hmm.
I only have these 3 on this file. We're adding more than that, right? Or no?
Yeah. There is propranolol, pyridoxine, and then technically Atrovent and activated charcoal.
Do you want to go to the list of table 2 and then we can kind of look at that? I know Shelley, you had annotated. My first question was about activated charcoal because we've removed that from all of the pre-hospital guidelines.
Yeah.
Based on input from the toxicologist. So I'm wondering if we shouldn't remove it from the tox box as well.
Yeah, I agree. I think that that was the one that was on my list to potentially strike.
Right.
Mm-hmm.
So I would probably avoid writing a drug profile for that one. And then that would go to MDC. We won't be able to get it on the agenda this time for September, but we could get it on. We could get table 2 on the agenda for January for update and review.
There's not already one on there for Atrovent?
There is.
Oh,
It's just listed as ipratropium. So I think that was the confusion on it.
Oh, okay. I was like, I know we have one for that.
We do.
Should we look at that and just make sure it covers the tox stuff too?
Yeah.
Mm-hmm. Although I don't know that there's anything specific for there. Is there?
That's true. Yeah.
I don't know if
Somebody
it's specific for
wondering-
tox, but it's on there for as far as a drug.
Tanner, can you think of any indication that for
I don't know.
Atrovent's tox specific that you guys have ever been taught?
Is it part of the hydrogen sulfide? Sorry, hydrogen fluoride poisoning, HF poisoning?
No,
It was.
it's calcium.
I think it's just bronchospasm for things like chloride inhalation or any of those.
Anything that's going to cause bronchoconstriction and
Yeah.
Because I'm wondering when I look at some of this list, I don't know that all of this needs to be on the tox box per se.
Yeah.
Right.
Things that are on like our regular drug table, unless there's specific dosing and quantities that we might want in a tox setting that we wouldn't want in a regular drug box, if that makes sense.
Yeah, I mean, I could see something like atropine. Is that what you're talking about? How our tox boxes usually have much higher quantities of atropine in them for that specific indication.
Mm-hmm. And then calcium gluconate as well.
Right. Well, calcium, yeah, for tox stuff, yeah.
I also didn't see, they have the duodot auto injector, but I know, I guess we do have those still. I'm just trying to think, because we have duodot, but then there's also atropine by itself.
Well, they used to have the Mark 1 kits, and then they've made it to duodot, I thought. And then you've got separate, I thought they still had separate injectors for just atropine.
They do, yeah. The atropine.
Yeah, something like that.
Yeah, they have like a peds atropine and adult atropine.
Well, I'm just looking at like, so we have it on, it is on table 1.
Mm-hmm. Is it linked to the organophosphate poisoning?
I'm just talking like the drug table where we just list like drugs and
Yeah.
who's approved to have it. So we have it listed. We don't have it listed as duodot though.
Right, because the duodot has the 2-cam.
So we have it listed as atropine sulfate and Pylodoxine combined auto injectors, how it's on table 1. So we probably need to clean up to make sure that it's just listed the same way. So I guess from a functional or operational side, what I'm trying to figure out is, do we think if something's on table 1, so it's approved for anyone to carry, would we need it also to be listed on table 2 for hazmat or tox? To me, it almost seems like we could eliminate, but I'm just trying to make sure, like, if we do that, would that mess with the ability to have like a specific drug tox box saying we would want these things in a tox box?
Yeah, I think that the power levels are different for the tox box drugs, right?
Well, the current one, it doesn't have, it just says minimum supply optional. So there's no PAR listed on table 2.
Oh, that's interesting.
Because that would also take, I'm sorry, yeah. Because that also takes into account, so we already have on table 1 the cyanokit, we've got calcium gluconate gel, we've got the auto injectors, we have a number, at least, a number of them already on table 1.
I just want to make sure operationally, like sometimes, when they took away the required hours for tox medics, then all of a sudden that requirement was gone. And so departments couldn't use that requirement to get funding. You know what I mean? So sometimes there's unintended consequences. So I just want to make sure, like Tanner, from an operational perspective, if this list cut in half and went down to only the tox specific drugs that aren't on table 1, which are our normal 911 drug bucks, do you think that would make a difference operationally for you, like trying to stock a tox box?
If I'm understanding correctly, you're saying like if it's already in for us the orange drug box, do we need to duplicate that same thing on the other page? I don't think we need to duplicate it, as long as it's referenced that whatever drug it is, it can be used in that scenario, toxicology wise. I think it's okay. I know the one I was just looking at, and this might be a little off topic. We carry protopan chloride. We carry it as we have to reconstitute it.
Yeah.
Do we need a separate drug profile for that? Because I don't think we have exactly for that purpose.
I think so.
Because we have the auto injector here. But
Yeah. Yeah, but the indications for the atropine and the 2-PAM are different, right? So they have like different indications technically. Yeah, protopam, optional. Yeah, they're all optional.
Yeah, I'm trying to figure out how, like, if we look at the list, because if we recommend removing activated charcoal, kind of going down alphabetically, albuterol, atropine, and atrovent are all on our current table 1. And then calcium gluconate's on table 1 as well, right?
Right, and then the
Both.
gel too.
Yep, so we've got that as well. We've got cyanokit, we've got dextrose, we've got diazepam, we've got duodot, although it's labeled separately.
Right.
Glucagon,
We've got glucagon,
not propranolol.
but so we need the methylene blue,
Mm-hmm.
propranolol, pylodoxine,
Mm-hmm.
pyridoxine,
Mm-hmm.
sodium chloride's on there. Sterile water is,
I mean, we have, we'd need so the Pylodoxine, we have half of it
yeah.
because we have the auto injector, just not a reconstitutable.
And we have tetracaine is on, right? Because we added
I don't think
prepared cane or tetracaine.
is that
So-
on page 1?
Yeah, we added it a while ago, so it's
Right, you're
near
right.
the bottom. It's proparacaine or tetracaine.
Yeah, you're right.
Because really, the tox specific, one of the things that we could consider there would really be 1, 2, 3, 4, 5, 6, 7
Mm-hmm.
drugs, and then we don't have saline on or sterile water.
No, I was another one I was saying we should remove from the list, but
Mm-hmm. Well, it's funny because we have lactated ringers is on table 1.
We have
Mhm.
saline. Wait, we do have normal saline on the
Am I doing-
list.
Am I missing it?
Normal above norepinephrine.
Oh, there it is. Thank you.
Page
Okay, so that
3.
one's off too. So sterile water, but I don't know that we need that on there.
Yeah.
So maybe what we can do is really narrow down table 2 or make that recommendation to MDC. We could put that on the PMD agenda. It would be to kind of narrow this down to the medications, and then reference anything that's on table 1 can automatically be utilized in the hazmat setting.
mm-hmm.
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 Pyridoxine. So methylene blue, propranolol, pyridoxine, I don't see either.
Mm-hmm.
It was.
And then for our normal drug profiles, do we have a duodot one on there already, Shelley? On table 1, it's got a different name, but I don't know if we had it on there. Can you pull up, sorry, the list of just all of our drug profiles?
Like the table of contents.
Yes, sorry. Yeah, the table of contents.
Yeah, so page 39, the Pylodoxine auto injector.
But that's not the combined.
Is it not? What does it say?
So we need to create then probably a drug profile for.
Duodot.
Mhm.
Mm-hmm.
So we've got the Pylodoxine. We just would need the duodot.
Do we have an atropine auto injector, by the way? I didn't look to, or do we just have it as
Just atropine.
atropine?
Yeah.
And then can we look at the atropine? I want to make sure that we cover like all the tox indications on there and link it to tox guidelines.
Yeah.
Yep. So we got
Nervate
Yep.
organophosphate, yeah.
Yeah. Okay.
Okay.
So that I think takes the workload down quite a bit then. So it looks like we got the sodium nitrite, thiosulfate, and methylene blue done.
Uh-huh.
We need one for the duodote.
Mm-hmm.
And the question is, I noticed this table too has a lot of brand names instead of generic. We probably need to remove brand names.
I don't know if there is a generic duodote.
Well, so I guess the question would be, we have it on table 1, we have it listed more generically. Atropine sulfate and Pylodoxine combined auto injector.
Oh yeah, I would match that. Yeah, I would put that verbiage.
Yeah.
Yeah, I just worry anytime you use a drug name that if they come up with, if there's other brands for it,
Yeah.
you're pigeonholing yourself.
Yeah, I agree.
Mhm.
I think like we did with Versed, Ativan, stuff like that, we also included those trade names in there so that they could be linked, right, Dr.
Right,
Riley?
you can link.
We did that on this
common
Southern
ones.
Arizona ones. Yeah.
So Shelley, instead of using the word duodote, I think we were going to use atropine and Pylodoxine combined auto injector. Is that what it says?
Mm-hmm. Atropine sulfate and Pylodoxine. PRALIDOXIME, and I'm reading it from another screen.
Good.
and then space, parentheses combined, space, and then auto injector. That's how we have it listed on table 1 currently.
And then you still want to keep the one that's just the protopam, the Pylodoxine, separate, because some agencies, I guess, could potentially carry that.
What do you think? Do you think we should have them separate?
They're separate in the drug box list right now. There's all
This
three.
list, I don't.
Atropine, there's duodote, and then there's the Pylodoxine separate. So they have them combined and separate in the drug table.
I don't know when last we actually reviewed this drug table, to be honest.
Mhm.
It's been a long, long time.
In a few years.
I think
God,
we
I remember-
added cyano but we didn't do anything else to it.
I think the other option would just be to have them as separate ones, you know, in the drug table. Have an atropine one, which we already have, and then just create the one for Pylodoxine. And then they buy a combined auto injector, that's fine, but in the drug table, have it be.
I think we would probably need to, it gets a little tricky in terms of like, even though it's optional, I would probably say like almost link them together. So kind of like the way we have methiodote or sodium nitrite and thiosulfate, I would
Right.
probably consider doing that same format. So, you know, the combined auto injector or
I agree.
atropine. So I would say maybe on the drug table, we do it that way.
Yeah, I think that sounds totally fine. But in the drug profile, we want to keep them combined because we already have an atropine, or do we just want to create a Pylodoxine drug profile?
I would say separate because it's not a huge workload to do it separate, and it may help us people, you know, from a training and educational perspective, kind of separating that out a little bit.
Yeah. And I do have notes for that one if we want to type that one up
Sure.
whenever you're ready, Shelley. Or I can even copy and paste it in the chat. Why don't I do that? That might.
I gave everybody editing rights if you want to jump on that link.
Oh, really? I can't find it. I'm just going to text it to you in the chat.
Yes, I can do that.
This is the Pylodoxine indication, or the pharmacology. is the indication. And this is the I didn't have a lot of precautions for this one. They were all for the atropine. Pylodoxine itself has, look at the quick. Most of the precautions were related to the duodote with the atropine portion. Contraindications. So this just says there are no known absolute contraindications. Not effective in the treatment of poisoning due to phosphorus, inorganic phosphates, or organophosphates not having anticholinesterase activity. Is not indicated as an antidote for intoxication by pesticides of the carbamate class, since it may increase the toxicity of the carbaryl. I don't know if that's useful.
I mean, I think the drug profiles are a teaching resource. I think if there's, I look at these as, I don't think people are using the vast majority of this on calls. The feedback that we got when we kind of looked at doing the first set to go along with the TTTGs is that many of the training programs, they utilize this for paramedics kind of first learning about a drug. So I think some of those teaching points are helpful.
Okay.
And I don't know what your thoughts are on that piece.
I use the drug profiles to navigate through the CARMs. So oftentimes I just need to recall, I know the drug, and because the dosages aren't broken down in here, I use that bottom guidelines containing that links me to my algorithm. So I actually use the drug profiles quite a bit as almost my index for finding the profile.
Got it. Those were the warnings for.
So sorry, so for the decision on the table, just making sure I'm still understanding. So the consensus is to have separate entries for the different formulations of Pylodoxine, whether it's a duodote, Pylodoxine by itself, or a protopam, and making individual drug profiles for each.
Yes. So kind of similar to the way the there's Thiosulfate, which is combined, or the sodium nitrate and thiosulfate. So it would kind of be that similar format on the drug table.
This one, so DailyMed says the onset is 16 minutes after a single injection. Peak mean plasma levels 34 minutes.
That's very specific numbers.
This is a very small study. Some evidence suggests that loading, blah, blah, blah. Half-life, 4 hours.
We can let the toxicologist weigh in on those ones. We'll put those as placeholders, 16, 34, and 4 hours. And highlight those for the tox input.
Exactly. I don't know. This is where
Do we need a reference on there for that? According to this article or this study.
Well, and this is from animal studies. Or some of it's from animal studies. It's on DailyMed. That's what Frank Walter uses to look up everything drug related. So
And you should be able to verify it pretty quickly.
yeah. They'll think, who else is using DailyMed? It's an NIH resource, and so he's all big on DailyMed. He thinks it's the best free resource out there.
I don't think I've ever heard of it, so that's good.
Yeah.
Another resource.
Yeah, I don't think I worked a single shift with him without him mentioning it or looking something up. In DailyMed. And we can change where it says protopam to Pylodoxine, I guess. I
Yes.
just copied and pasted that from.
Pylodoxine.
Protopam chloride. We just say Pylodoxine.
And there's a second one on there too.
Yeah. What was the other one you needed? Propranolol?
Yeah, there's propranolol on the list.
So, Franco, what are your thoughts as this will go to PMD kind of in November, proposing the updated drug table with kind of cutting this down essentially less than half of what it currently looks like to being only drugs that aren't on table 1. And then referencing table 1 drugs can be used in the hazmat setting.
Well, it depends. So for the purposes of just the table, so just the listing on table 2, I would advocate showing all of the drugs that could be potentially deployed on a hazardous material call. When it comes to the drug profiles, I don't see a distinction there. I don't think there needs to be 2 sets of drug profiles, one for the CARES guidelines and one for a ToxMed guide reference. But for this, well, it was on the screen a second ago. For just the list of table 2, I don't think it's a big lift to have them all neatly listed under one table. Does that get to what you're asking?
Yeah, I think that's why I wanted to clarify, because you hadn't spoken about that, because I think we were all kind of leaning towards removing those and just paring it down to kind of clarifying these are the drugs that only toxmedics can use, because it's a little confusing, and especially like when you look at the 2 tables, we've got the same drugs listed with different names, which is definitely some housekeeping, but
yeah. I mean, if the table 2 white document that we're looking at on the screen right now is more along the lines of drugs that are restricted to hazardous materials incidents, then I agree. Then we remove everything that would be otherwise found in the medic box.
Yeah, I think we've just added so much stuff to table 1 that there's now significant overlap.
Yeah.
But yeah, I don't think that the medic teams or the hazmat teams are using this as a resource for what to put in their box per se.
Fair enough. Yeah, if it's not being used that way, then I'm cool with removing as much as you can.
I think part of that is trying to clean up some of the drug tables, because I think there's some confusion about what can actually be used where. And this, once we get down to the actual tox drugs, this is really a limited number that is very specific to tox medics with training. And so that's why I thought it might be more clear if we kind of just narrow it down.
Yeah, because otherwise half of these drugs are authorized technically for any paramedic to give.
Yeah, no,
or over half of them. It's a lot.
Yeah, 12.
Yeah.
I just want to make sure you are comfortable that Franco, because it'll be coming to you.
Yeah, that's fine. Yeah, it makes sense. For some reason, I was still thinking that somebody somewhere needs a more comprehensive list of that's all inclusive, not selective. But
yeah, I don't think they do. But
all right, what do you want me to display next?
You want to create a propranolol one?
Oh, yeah.
Yeah.
Okay.
That's what I have for propranolol.
Blocker.
And I don't know how specific we want to be for this. So if you think about the sort of tox indications for it, we tend to use it for hydrocarbon toxicity. Dysrhythmia is associated with that, but I don't know if we want to be more broad in our indications for that. 'Cause if it's only carried on the tox box, it's only going to be used for a couple things. So I don't know if atrial fibrillation would even be appropriate necessarily.
It's probably not the best one for that.
Yeah, well, it just is on the tox box, so it's only on the tox
Yeah.
box.
Sorry,
So,
I was on mute. I would say I would keep it to the tox indications
Mhm.
because
Yeah.
that's all that it's approved for. So we shouldn't be using it for like non-tox related.
Perfect.
Because it says during a hazmat incident at the top of the actual drug table.
Yeah, so I would say get rid of the dysrhythmia, the top dysrhythmia bullet for indications, and just keep dysrhythmia is associated with hydrocarbon inhalation or exposure. And I don't know, these absolute contraindications I got from DailyMed, so. We can reword them or rework them any way you guys want.
I always question the asthma contraindication with beta blockers.
Put it in precautions maybe, or just delete it.
I mean, do you ever hold beta blocker because someone's an asthmatic?
No, I don't.
I don't either.
So just delete that one.
I would.
What about the sinus bradycardia one? Should we put that in precautions and not absolute?
I would think it's absolute, right? Because if they've got,
Yeah, you could.
If they're already
It's-
pretty bradycardic, I'd be
Yeah.
concerned about giving them
Yeah.
more beta blockade.
Oh, and then I need to find the pharmacokinetics for that one. And I would even in the indications say symptomatic dysrhythmias. We wouldn't give it if they're asymptomatic in general. But I don't know, maybe the toxicologist would disagree with me on that one. But
I think symptomatic's good because if someone's got a dysrhythmia and they're asymptomatic, I don't think we want to go giving them something that could then
yeah,
cause adverse reaction.
yeah. Generally it's like PVCs and stuff like that. Pharmacokinetics on this one.
Effects.
Here we go. So distribution half-life, 5 to 10 minutes.
What do we need under precautions and side effects?
I don't think there are any.
Well, we have PRAL listed. I didn't know what that was.
Oh, yeah.
Was it
Copy and paste.
leftover from before?
Yeah.
I guess would you say bradycardia
Bradycardia is where I was
would be a
thinking.
side effect?
I mean,
That's my doctor prompt word. All right, precautions and side effects. We're going to add Rich.
I think bradycardia, right?
Mm-hmm.
do we need hypotension with it or no?
I'm showing nausea, vomiting, diarrhea.
I don't know if that's very common, is it?
I'd say we probably want to put like any, things that would be concerning for the EMS providers. So I think hypotension, bradycardia, what I see listed,
Heart block,
heart block.
Yeah.
CHF.
You've educated all of us on DailyMed. Frank will be so proud of you, Amber.
Uh-huh.
I had not heard of it either. Had you, Franco?
I wake up every morning and just peruse these pages
Just
randomly.
search the DailyMed.
Yeah, I just roll the dice and start memorizing stuff.
Yeah, it's from it's the NIH's like drug database. It's got like information, and so it's free. So Frank's all about it.
Yeah, no, it's really helpful.
Right.
I wish I'd known about this when I was trying to put together the original amount of drug profile.
That's what when we made all the tox medic stuff for all the tox classes. That's what we basically just like pull it all from DailyMed. It's all researched and good information.
Sorry, precautions and side effects. It'd be bradycardia, heart block, hypotension. Hypotension, then and CHF.
Yeah. But then not the nausea vomiting, right?
I don't think we've put that type of side effects on the other ones.
I don't think we need it. We'd definitely have been a little more selective on our side
Mhm.
effects.
And I'm just looking for the onset peak stuff.
I think it's like 5 minutes for onset. Distribution half-life, 5 to 10 minutes. Elimination half-life, 2 to 5.5 hours. No, it's all I can find on here.
We can let the tox ones review those too. You can keep that note, Shelley.
Yeah, bold or highlighted, that way we don't forget it.
And what guidelines have that? Do we have one?
Do we have a hydrocarbon one? I don't know
I'm
that-
gonna see right now in the app.
So
I
we'd
don't
have to
think
make we'd have to make a hydrocarbon one. So we need a carbon one.
Shelley, can you keep us within rules? Are we allowed to work on, can this group put together some guide TTTGs for the missing ones to go along with the drug profiles, even though that wasn't our action item from the
Yeah, it
PMD
sounds
meeting?
like it's against the rules.
Against the rules, you said?
Yeah, that does not sound like proper procedure to slap
Okay.
that on right now.
So we need to go back to PMD and get an authorization, put that on the agenda to get an okay to work on it?
Right.
Can't you just bring it to PMD separate as an agenda item? Does it
How
have
do we do? We did it somehow with the VAD one. What did we do with VAD? I know there was something that was
we just made it?
because we were doing the PowerPoint, the training. We realized that we needed to separate the VAD and total artificial heart as part of that training.
Yeah, I think we just copy and pasted it into a separate one and made a new one.
Yeah, there's just some
Because-
open meeting rules we have to follow. That's why I wanted to ask Shelley just to make sure we.
Well, we were gathering all those bad center people at once.
Mm-hmm.
It kind of got administratively okay to proceed with that.
Yeah.
And then it got added as a separate agenda item.
So we can look at, well, we'll at minimum have all the drug profiles and a proposed updated drug table. And we will find out before we have a follow-up meeting on this one, if we can look at potentially linking that, since we now have drug profiles for our drug table and we're missing.
Mhm.
So we'll be non-committal on that and let the group know at the next meeting. We'll figure out.
But what we need are hydrocarbon and the methylene blue.
Yeah, we have nothing for methylene blue.
Is there another one we didn't have one for? Propranolol, methylene blue.
Well, the propranolol goes with a hydrocarbon, right?
Mhm.
Yeah.
And then the methylene blue,
the
we have,
various Pylodoxines, the ones that you were showing, Shelley, and when we were editing those, did not refer to any specific guidelines.
Oh, yeah.
So
It should be the organophosphate one
The
because we have organophosphate. Wasn't
Yeah,
linked to that.
Right there.
Yeah, we should link to that one. Good catch, Franco.
pyridoxine.
Carbon methylglobinemia.
I was going to ask you to scroll down, Shelley, and then I realized I can just look at my version that I'm in right now.
I'm happy to listen to any guidance anyone wants to give on what to look at next.
Right, so we've done methylene blue, sodium. Do we need to do a separate nithiodate? Kind of like the way we.
Think
Pardon?
so.
Okay.
I don't know. I mean, when you look at how it's dosed, I mean, usually you would give, depending on the symptoms, like 1, 2, or 3 of the duodotes. Or 2 or 3 of the duodotes, depending on the symptoms. But if you're dosing them separately, obviously I mean, you're drawing up the medication, giving it. But it's for the same indication, right?
Mhm.
It's just a dosing thing.
So the guidelines shouldn't change. It's just the
drug profile was my question.
Profile.
So because
Yeah.
we have on the table, we have it listed as nithiodate or sodium nitrite and thiosulfate. So we've got the sodium nitrite, we've got the thiosulfate. Do we need to do a drug profile for the combined?
I don't think so, because it would just be literally combining those two in one sheet, right?
I would vote that we do that then, just
Okay.
so that people understand, like if they're using that it has both effects.
Yeah, we can certainly just combine those. But that would be the effect, right?
Mm-hmm. Yeah, we're basically just combining the pharmacology indications. All the other pieces would just be those two combined.
Makes sense.
And then Pyridoxine looks like the other one that we don't have a guide. I don't think we have a guideline
Oh, yeah.
for it or a
That's
drug.
right. I wrote that one. This one's like also very short.
Yeah.
I'll throw out what I had.
UIR, the one with the 9. Yeah.
Pyridoxine.
They actually listed in DailyMed INH and birth control pills
Huh.
as being causes of drug-induced pyridoxine deficiency. So I deleted the birth control pills.
Where are you looking in DailyMed for this? Like I'm on DailyMed, but I'm trying to, I couldn't find like the time frames on everything. I mean, I see like the regular drugs, but as far as uptake
Like
and
you just have to open up the like pharmacologic part and read through the studies.
oh, okay.
Read through what they
Oh, I
had.
see. Clinical pharm. Okay. Got it.
Yeah. Sort of like summarize what's known about the pharmacokinetics.
Okay. So it's just each within.
Yeah.
Okay.
I don't know.
What guideline is the pyridoxine?
I don't know if we have one for that either.
So, yeah, the question that I have from the indication is, do we need to be more clear of like, why would a tox medic
Sure.
be giving this? So they wouldn't know that the patient has a pyridoxine deficiency. So like,
But seizure. for
yeah,
whatever
so it's
the-
like what we're referring to is seizure related to
True.
isoniazid or INH
overdose.
toxicity.
Yeah. Uh-huh.
Gotcha. That makes more sense.
Yeah, I was trying to think of like how to word that, but I think it would be seizure related to isoniazid parentheses INH toxicity.
Yeah,
Mhm.
I like that.
What about, I mean, the teaching in just general emergency medicine is anyone with a refractory seizure, you'd give this empirically. Would that be in the context of a typical EMS pre-hospital toxicology call? I don't think so.
Yeah, I
Mhm.
agree with you.
I would limit it.
It's kind of an odd one that it's on the tox table, the hazmat, you know what I mean? Because it's like
Yeah.
like under a hazmat incident. I can't imagine this being dispatched as a hazmat incident.
No, they sort of
Seizure.
conflate like hazmat with, most of these teams aren't just tox medics. Like they don't deal with
Yeah.
ecologic issues. They deal with hazmat incidents.
Yeah.
I don't know that they'd ever run a call where they would give this, but I don't know. It's one we could think about taking off, but I don't.
What are your thoughts on that, Tanner? Kind of being hazmat and tox medic operationally.
As we've seen toxicology and the drugs and stuff moved specifically to the hazmat teams and get away from every unit having it, it's just unrealistic for us to respond to a call where a crew has that going on. We've kind of scaled it back to say, well, what would we be exposed to on a scene and how would we treat ourselves?
Right.
So I'm not even really familiar with this one specifically. So
Yeah, this is starting to sound like a remove to me.
I agree.
Yeah, we can vote on removing this one.
Yeah, because I mean, the things you think about hazmat teams are things like the hydrocarbons, because they can encounter those all the time, and the, you know, some of these other things. But even, you know, when we teach the toxmedic class, we talk about things like huffing, and you're like, a hazmat team's never going to get called out on a huffing call. I mean, just
Right.
talking about like multi-patient incidents, and I don't know.
And I mean, to be honest, INH overdoses is not, it's not like usually a group effort.
Yeah. True. Well, you
There's
don't
no harm
recognize it.
associated.
Well, yeah.
Yeah. And you would never recognize it in the pre-hospital setting.
No, outside of like having an empty bottle there and
Yeah.
a really good history.
So do we have all of them then?
Yes.
What did we decide on sterile water? Because we had sodium chloride, so we have saline. We don't have sterile water. Do we even need it is the question.
Oh, yeah.
I think we talked about it when we did the previous ones. I think we figured like I don't know why you would come up with a drug profile for water because it's not really a drug. Well, it's not a drug.
Yeah.
So I would say no. We can keep it on there, but I wouldn't, because it's one of the things that are needed, I think, for some of the tox indications, but I don't know that we need a drug profile for it.
No, because it's just something you use to dilute stuff.
Reconstitute and
There's nothing that you couldn't reconstitute in sterile water.
Yeah, I'm not thinking of many contraindications or side effects outside of just saying dumping a whole bunch in, but yeah.
Yeah, I agree. So we're recommending removal of atropine and propranolol, atropine and pyridoxine. So that leaves us with 6 total, 7 if you include the duodose separate.
Well, I think so. Let's see. If you can go to the top, Shirley. So I think activated charcoal, we're going to recommend removing. Albuterol, atropine, atropine, calcium, cyanocate, dextrose, diazepam. Those are all in table 1.
As is glucagon, right?
Yep, as is glucagon, and duodote as well.
And duodote is just a thiodote. Oh, duodote's on the table 1? Oh, yeah. Okay.
No, the duodote's the atropine,
Yeah.
Pylodoxine.
Oh, yeah. You're right. Got it. Okay. So we have duodote on table 1 already?
It's just, that's where it's got the
It's
different
not called
name.
it.
Yeah. And did we have a drug profile for that? Or we did not? We were going to combine?
Yeah, we need to create one for that one. So I think on the list of drugs, pretty much everything.
We don't need to create it. We just need to reference it though, because it's organophosphate poisoning. So isn't it? We just need to reference the table.
We don't have a drug. I don't think we have a drug profile for it.
Oh, the drug.
Yeah. No, we
Okay.
did. We made the combined one. Yeah, we did make that one.
Yeah, we did. Yeah.
So sorry. So we're all on the same page at the top of the drugs. So activated charcoal, we're going to recommend deleting. But I would just highlight, Shelley, from albuterol all through glucagon. Those are all on table 1.
Yes.
And then it would go down to methylene blue, and then the rest down through pyridoxine we are going to keep. And then sodium chloride is on table 1, and tetracane's on table 1 as well.
Repeat for Protopam. That's staying as is. We already have that.
Yes. And we had one for that, right? Yeah, I think we already had a Protopam or Pylodoxine drug profile.
Yeah.
So the only guidelines you need then are like a methemoglobinemia for methylene blue and a hydrocarbon guideline for the propranolol.
Mhm.
Mhm.
Is that right?
I think so, yeah.
So those are the only two we'd be missing.
I think
What
so.
was the other one besides hydrocarbon?
Um,
Methylene blue?
Yeah, for the methylene blue,
Methylene.
we don't have a guideline for it. We have drug profile, but no guideline. And for the hydrocarbon, we also have a drug profile, but no guideline.
We got a lot done in this meeting today.
Yeah, thanks to Tanner for the head start.
Yes.
Thank you, Tanner.
Yes, thank you.
My brain is in the weeds, so
So we will follow up regarding the TTTGs, and if we can do that, and then maybe schedule another meeting for late September.
Mhm.
Cool.
To reconvene.
Works.
Can I ask a question about the table 1, table 2?
Yes.
This document here, does this determine like how much training or what people like? What's the application for table 1 and table 2 in my world? Like, is that what we are able to carry? What we're able to use? How do I use this?
So good question. So table 1 is specific to anything that any paramedic or EMT in the state is what they're allowed to utilize. So it's based on any certification level. So if you're a paramedic, you can use any of these medications. The actual quantity and amount is determined based on this. So if it says minimum supply, that means you have to carry that at all times. So like adenosine, 18 milligrams, that means that's the minimal you have to have access to utilize. So that's table 1. Table 2 is specific to hazmat or tox medics. This is a little bit of a gray zone because there used to be in rule minimum requirement to be a tox medic and for ongoing training. At some point that was removed from rule. And when that was removed, we now have this nebulous like reference to hazmat incident and tox medics, but there's nothing in rule that outlines what that minimum training should be.
Would it be fair to say we've always worked out as far as when we teach here in Mesa about STRs, the special training required, that those drugs should fall under that category? Because I'm looking at table 1 drugs, like going through paramedic school, I don't know of very many paramedic programs that teach you how to use or do the, let's just say the cyano kit, right? We teach everyone proparacaine because nobody's really ever seen it or heard about it in medic school. Same thing with calcium gluconate gel. Those types of things I think are specific that don't necessarily get taught or instructed. So I'm just wondering as far as being able to use and having it just freely on one page versus having it, hey, you can carry it, but you also need the training behind it.
Yes, so that is a very good point. I think the kind of at the top, it talks about your administrative medical director has to approve you being able to utilize those. So it's kind of up to, it falls in your administrative medical director to essentially make sure that you are trained if you're going to use those medications. So any of the optional medications definitely fall under that. In terms of changing this to STR, that is something that would have to do a rule writing change on, because special training required is really specific to kind of scope of practice. So it's a weird rule writing process, which is very slow and ineffective. Not ineffective. It's a slow bureaucratic process that takes like years, literally, to update a rule. But I think your point is very good that many of these drugs people aren't trained on, but that's where the requirement of your administrative medical director should ensure that your agency has trained you on using those drugs.
Yeah, I think that it's sort of a way around the STR for these. We've in effect created an STR by wording it the way we do and having it as a separate drug box. Having it be not required, no minimums, it creates the same effect as having an STR. And so because every department has different requirements for being on a hazmat team, I think it's just sort of the way it is because of not having any regulation over the training of the hazmat teams. But yeah, I mean, it's your point is valid. This is our way around it, I think.
Yeah.
Thank you.
Yeah.
And that's why I say anytime stuff gets removed from rule, I think that was an unintended consequence, that when it was removed from rule, they didn't realize that that requirement in rule helped cities get funding, because it was like, no, we have to demonstrate these hours to maintain this. So you could fall back on the rule to justify funding. Now that there's no minimum requirement in rule, it's hard to justify that funding, or harder, I should say.
Right. What I run into a lot, because these are super low frequency, and a lot of them are expensive, and just the maintaining of training even is the one that we struggle with. You know, if they're not getting it even in medic school, when they're coming to us, we have to build a base, and then we have to continue building that. So
Yeah. Agreed.
Yeah, I think our hazmat teams have a much higher requirement for education hours per year. So I'm sure all the hazmat teams do.
But that's kind of department specific versus like in rule.
Right.
It's not state.
Yeah. Well, thank you guys. That was
Thank you.
a lot of work, and we got quite a bit done, and we'll work on some dates for later in September.
That works. Thank you.
All right. Thanks, everybody.
Thank you.
thank you.
Okay.
Bye.
Thanks,